Now I'm going to do the check off for nasogastric insertion and the enteral feeding. So for the insertion of the nasogastric tube, the first thing I'm going to do is check my physician order. And then I'm going to identify my patient with their armband against their procedure card. Then I'm going to wash my hands, gloves. Next thing I'm going to do is put my patient in high Fowlers as long as it's not contraindicated for my patient. And it's not, so we've got them in high Fowlers. Now I've got them a tablet to put across their chest. I'll have them ice chips, water if they're able to swallow. I'll have them tissue and an emesis basin in case they get nauseated. And then the next thing I'm going to do is check for patency. So we're going to occlude one nostril, one there, and make sure that they can breathe out of the other. And he's doing that just fine. So next thing that I'm going to do then is put the tube over here and go ahead and measure this tube to be for this patient. So the way we do that is we go from the tip of his nose to the tip of his ear, all the way down to his wing process. And once we get to where that is, I'm going to go ahead and mark that with a little piece of paper. Where to stop. Now I'm going to go ahead and lubricate my tubing about 3 or 4 inches pretty liberally, so it's as comfortable as it can be for the patient. So then the way I insert it is I'm going to push it back and down. I'm going to have the patient to, if he's able to, tilt his chin down and swallow. It's okay to do that. And then go all the way to this tape as long as the patient doesn't exhibit any gasping, cyanotic, coughing to the point where he can't breathe, any distress, or if I met some strong resistance, I would discontinue. He's doing fine. So got to our point, and I'm going to temporarily take this to the patient, just be for temporary, because we've got to check our gastric, make sure that it's placed properly. So the way we do that, I'm going to have to get a little bit bigger tape. So we're going to do a little bit bigger of a tape for this patient. And then we're going to aspirate out contents to make sure that this is placed in the proper place in the patient. So the way we do that is we get a big syringe and we attach it, not to the blue part, I don't want to stick to my patient too good, but aspirate content out of there. We would stick that into a cup, and then we would place, don't want to stay, we would place a pH strip in that and make sure that it's right. And if it is placed right, then we can go ahead and put this on more securely. So you can do that with an NG tube holder, or you can do it with tape. If we didn't do, well, we could do the pH test and a chest x-ray, or either or. The chest x-ray is the best way to be more positive that we're doing this correctly and that it's in the right spot. So we're going to take this tape that I have, because I don't have an NG, and wrap it around. So now that we have that secure to the patient and we know that we're where we need to be, go ahead and secure it, hook it up, but we're going to look at the physician's order and see how he wants it. If he wants it to go to a feeding, if he wants to go to suction, or if he wants it to go to be clamped off, and then we secure it here too, but it would be up here, hooked up. We're done, so then we're gonna take our gloves off. And we're gonna wash our hands, and we're gonna document, and we wanna document the size and the placement of the tubing. We want to put which nair it's in, how the patient handled it, what the pH of the gastric residual was, and how the procedure went. All right, now we're going to go into the enteral feeding for this patient. And so what we would want to do for that is check our physician's order. And then we want to come in and identify our patient. To make sure that we check for allergies for this patient, make sure they're not allergic to anything, and then wash our hands and go ahead and swab. I'm gonna go ahead and prepare the patient's feeding by shaking up his hand and placing it into the correct bag. And also, if my patient isn't already sitting in high fallers and he's able to, I would have him sit in the high fallers. So we've got his feeding ready, got the tubes hooked up. But the first thing that we've got to do before we do all that is we actually have to check, and we want to make sure that this tube is still placed in the right spot. So we would take that out and check that pH level again, make sure that it is right. If it's right, we can hook up the feeding. And then if we get less than 250 ml, then we need to go ahead and add two for replacement. If we get greater than 500 ml or 250 ml an hour apart, then we would need to stop the feeding. So we're going to flush with 30 ml, and then we're going to hook up the NG feeding tube. And then we got to decide what our physician's order is. If it's a bolus, then we hang that to gravity and we let it finish, and when it does, then we flush with the 30 ml. If it's a continuous feeding, then we will come in every 4 hours and flush with the 30 ml. Then after that, if it's the continuous feeding, then we're going to come in and we're going to check every 4 to 6 hours for residuals. And then once we've done that, check for the residual every 4 to 6. Okay, now we're looking at we check that. Okay, so the bag has to be changed. The feeding bag and the administration set has to be changed every 24 hours. And if it's an abdominal, then we have got to come in and we've got to assess that daily, and we have to clean that daily. That's it. Then we're going to document. Take our gloves off, wash our hands, and document. We want to document how the patient tolerated the feeding, how much residual that there was. If they had any nausea, we would put that, and then how much intake and